Okay, let's just dive right in.
Let's do it.
We're starting today with this really compelling and honestly pretty frustrating story from one of our sources.
It's a frustrating one.
It really is. I mean, just picture this. You have a patient, they're all scheduled for a major surgery.
Right.
But while they're waiting, they get introduced to this treatment that's framed as a magic weapon.
An artifact, even. They're using this really loaded language.
Exactly. It's called proton therapy.
And it's the ultimate marketing hook, isn't it? The patient, they think they're getting the absolute best, the cutting edge. So they go for this really expensive therapy.
Now, here's the twist.
The twist is that they later felt this whole adventure, this magic weapon, actually made it harder for them to get the surgery they wanted in the first place.
Which just leads to this immense frustration, a lot of money spent, and feeling like you're worse off. So that anecdote really, it sets our mission for today. We have to get into proton therapy.
We do?
We need to cut through all that hype. What is this technology? Why does it get people so excited? What are the real benefits?
And crucially, why is the expert in our source material warning everyone not to mythologize it?
Right, to focus on limitations and cost.
That tension, between this amazing, expensive tech and what's actually right for a patient. That's the whole story right there.
So to understand proton therapy, I guess we have to start with radiation therapy in general, RT.
Yeah, you have to understand the foundation first.
And RT is it's a huge part of cancer there. Our sources say something like 60 to 70% of patients with malignant tumors will have radiation at some point.
Oh, absolutely. It's a cornerstone. It's not an add-on. It's central.
So how does it work, just as a refresher?
Well, the basic mechanism is pretty powerful. RT uses what's called ionizing radiation, these high-energy beams, to just damage the DNA inside the cancer cell's nucleus.
So the cell can't divide anymore?
It can't replicate. It loses its viability, and basically it dies. It's a very effective way to get local control over a tumor.
But the classic problem has always been, collateral damage.
Right.
You have to shoot the beam through healthy tissue to get to the tumor, and then it keeps going out the other side.
Damaging cells on the way in and on the way out. That's where a lot of side effects come from.
And we should probably pause here and say that modern RT is already incredibly good.
Oh, absolutely. This isn't some archaic technique we're talking about.
Nah.
We have things like IMRT, intensity modulated radiation therapy.
Okay, unpack IMRT for us just for a second. Why is that already such a big deal?
Well, IMRT was a huge leap forward. It uses computers to precisely shape the radiation dose. So instead of one big square beam, you might have hundreds of tiny little beams coming from all different angles.
All converging on the tumor?
Exactly. And the intensity of each one is varied. You're basically sculpting the dose to fit the tumor's exact 3D shape, sparing as much healthy tissue as you can.
And things like CyberKnife or Gamma Knife, they're all in that same family, right?
They are. They're all different ways of using photons, X-rays, in a really, really precise way.
So if we're already that good at sculpting a dose with conventional RT, why do we even need something new? What's the problem that proton therapy solves that IMRT, with all its sophistication, still can't?
And that is the perfect question. Because the limitation isn't the technique, it's the physics of the photon itself. An X-ray beam, just by its nature, deposits energy all along its path.
The whole way through.
The whole way through. IMRT is brilliant at minimizing the dose outside the tumor, but it can't get rid of that exit dose. The X-rays have to leave the body, and they're still depositing energy on the way out.
Okay, and this is where it gets really interesting.
This is the fundamental shift.
This is proton therapy.
Right, so proton therapy uses, high-energy protons instead of photons. And protons have this bizarre and incredibly useful physical property.
This is the Bragg Peak.
This is the Bragg Peak. Unlike an X-ray, you can fine-tune a proton beam to travel a very specific distance into the tissue, release almost all of its destructive energy in one sudden burst.
And then just stop.
And then essentially stop. The energy delivered drops almost to zero right after that peak.
So you can literally tell the proton, go 7 centimeters in, unleash everything, and then you're done.
That's the entire idea. Imagine you have a target inside a priceless glass sculpture.
Yeah?
Conventional radiation is like a high-pressure hose. You're going to damage the glass on the way in, hit the target, and then damage the glass on the other side.
All right.
A proton is like a tiny smart bomb. You tell it to only explode when it gets to the very center of the sculpture, leaving the glass behind it completely untouched.
That is a game changer. It's not just reducing the exit damage, it's basically eliminating it.
It is, and that unique physics, that's where all the clinical advantages come from. That's why there's so much hype.
So let's outline those advantages from the Bragg Peak. Number one is obvious. Much less damage to the healthy tissue right behind the tumor.
Yep. But the second one is, I think, even more important for a patient's long-term health.
Such as?
Lowering the risk of secondary tumors.
Because the radiation itself can cause cancer down the road?
Exactly. Radiation is a carcinogen. If you can drastically reduce the amount of healthy tissue that gets any dose at all, you are significantly lowering the risk that you'll cause a new cancer 10, 20 years later.
That's a massive deal, especially for, say, younger patients who you expect to live for decades after treatment.
It's a huge quality of life issue. And the third big advantage comes from that same precision. It can be an option for re-irradiation.
So if a cancer comes back in a place you already treated.
Right. Usually that's incredibly risky. The surrounding tissue has already taken a lifetime dose of radiation. But because protons are so precise and spare that surrounding tissue, you can sometimes go back in and deliver another curative dose.
So when we look at who this is best for, we're really looking for tumors near something very sensitive.
Or in bodies that are still growing.
Children.
Childhood tumors are number one on the list. For a child, you're not just trying to cure the cancer, you're trying to preserve the next 80 years of their life. You have to minimize damage to their developing brain, their bones, their organs. It's absolutely critical.
Okay, that makes perfect sense. What about in adults?
In adults, it's all about location, location, location. Head and neck cancers are a prime example.
Because everything is so crowded in there.
Incredibly crowded. You got the brain stem, eyeballs, optic nerves, the spinal cord. Sparing just a millimeter of dose to one of those can be the difference between a patient seeing or not seeing, or being able to swallow.
Also spine tumors, eye tumors, places where there's no margin for error.
Exactly. And deep body tumors, where a traditional beam might have to pass through the heart or a major lung to get to its target. All of those cases are where this tool really shines.
This is where we have to bring it back to that opening story.
This is where the reality check comes in.
If the physics is so much better, why isn't it for everyone? And the expert in our source is very clear about this.
Very clear. This is not a magic weapon. It's a highly specialized tool, and it has strict limitations.
So let's talk about where you don't use this specialized scalpel. What are the contraindications?
Well, there are a few definite no's. First, if a site has already had radiation more than twice, even protons are probably not a good idea. The tissue is just too damaged.
Okay.
But the second one is maybe the most important strategically. It is not for late stage, multiple metastatic or terminal disease.
Because it's a local treatment?
It's a local treatment. If the cancer has already spread to the liver, lungs, and bones, zapping one of those spots with incredible precision doesn't solve the bigger systemic problem.
But wait, why is it actively inappropriate? Couldn't it help with, say, pain control in one spot?
That's a good question. And sometimes it might. But in general, it's considered inappropriate because of resources and focus. A patient with widespread disease needs systemic therapy, chemo, immunotherapy, something that treats the whole body.
Right.
Spending a huge amount of time and money on a single spot that won't change their overall survival. It's often not the best use of that patient's limited time and financial resources.
That makes the distinction between local and systemic control really clear. Okay, what else?
The target itself has to be stable. So gastrointestinal tumors, think stomach, bowels, they're not a primary focus right now.
Because they're always moving.
They're always moving. It's called peristalsis. The Bragg Peak is precise to the millimeter, but that's useless if your target is shifting around by a few centimeters every few seconds.
So your perfect aim doesn't matter if the target is dancing around.
Exactly. And of course, it's not for blood cancers like leukemia, which are everywhere in the body.
Okay, that list already debunks the whole cure-all idea. But what about really common localized cancers? What about something like breast cancer?
This is where it gets really interesting. For breast cancer, the experts' analysis shows absolutely no advantage.
None.
None. The outcomes using modern, sophisticated photon therapy like IMRT are just as good. The anatomy is such that you can already spare the heart and lungs very effectively with standard techniques.
So there's no clinical reason to justify the massive extra cost?
Not for most breast cancer cases, no. And we even see that nuance within a single organ. Take lung cancer.
Okay.
For a tumor on the edge of the lung, a peripheral tumor, traditional methods might be just as good, or even better, but for a central lung cancer,
None that's right in the middle of the chest.
right next to the heart, the esophagus, the major blood vessels, That's where proton therapy has a much bigger advantage.
Because you can hit that tumor and just stop the beam before it goes into the heart muscle.
Exactly.
Hmm.
You're potentially reducing the risk of long-term cardiac damage, which is a very real side effect of radiation to the chest. It's an advantage born entirely out of proximity to critical organs.
Which brings us right back to the patient from the beginning and the cost.
And the cost. We have to talk about the cost.
It's known to be astronomical.
It is. A proton center can cost hundreds of millions of dollars to build. These are massive machines. And the sources really stress the physician's duty here.
So how does a doctor have that conversation? A patient comes in, they've heard about the magic weapon, they want the most expensive thing because they think it's the best.
The doctor's job is to bring them back to the evidence. To talk about cost effectiveness, the conversation has to be, can I get you the exact same outcome, the same chance of cure, the same side effect profile, with a cheaper, standard treatment?
And if the answer is yes,
Then the standard treatment must be chosen. It's a moral obligation.
why must? I mean, if the patient can afford it.
Because the doctor's summary is explicit about this. Expensive does not mean best, and cheap does not mean bad. To put a patient and their family through enormous financial pressure for no tangible clinical benefit is, frankly, irresponsible.
The story we started with is the perfect example of that breakdown.
It's the real-world result when you don't put suitability first.
So the biggest lesson here isn't really about the technology, it's about how you apply it.
Absolutely. The final message is so clear. What is suitable for the patient is the best. That's it. Proton therapy is a fantastic tool. Its safety is known, its effectiveness in the right cases is certain.
But we can't mythologize it.
We cannot. We have to treat it like a precision instrument, not as the bane of cancer.
So we've established the Bragg Peak is brilliant for minimizing collateral damage, but its use is really narrow. It's limited by tumor location, by prior treatments, and critically, by that cost-benefit analysis.
And that all points to a bigger truth. Cancer treatment is never about just one thing. It has to be comprehensive, multidisciplinary. It's the smart integration of surgery and radiation and systemic drugs that gets the best results.
Which brings us to our final thought for you, the listener, to mull over after this.
Yeah, so think about this. If even our most precise, most advanced local treatments like proton therapy are only right for a small subset of patients and can't do anything for widespread disease, what does that tell you about the absolutely critical, non-negotiable role that systemic treatments have to play? Things like chemotherapy, targeted drugs, and especially immunotherapies that are evolving so quickly. How do we best balance that need for total body-wide control with these incredible advances in local precision? That's still the biggest challenge in oncology today.